Oh. Okay. Can the folks online hear me? Okay, awesome. All right, so first of all, welcome to this colloquium. We really appreciate you coming, and feel free to grab some lunch. We're honored today to have several guest speakers, and we have a number of folks online. We also have, we're going to hear about some really exciting research and really a focus on engaging communities to conduct impactful research. So this topic is a really important one, very central to the mission at DePaul and within the College of Science and Health and part of designing DePaul. I feel like we have, it fits very well with our focus. So I wanted to give you just an outline of, so we have 3 guest speakers today. Each is going to be speaking for about 15 minutes, and then we're going to have questions at the end and discussion about 20 minutes, and we end at 1:30. So I wanted to first acknowledge the colloquium committee. So we have Annie Saw, who is online, and she actually, we've had some really exciting colloquia this year, and we had kind of a different approach to some of the ones we've done in the past. And she kind of spearheaded this initial, this idea and reached out and got things rolling with this initiative. So I want to thank Annie. We also have Tashika Weber-Ritchie. We have Deacon Joe Ferrari. We have Emily Barnard, myself, and Dina. And so we have our 3 speakers, Dr. Maria Ferrera, who's an associate professor, social work and critical ethnic studies, Dr. Ansuk Jeong, who's an assistant professor in community psychology, and Dr. John Mazzeo, who's an associate professor in health sciences. Those are our 3 speakers. And we are honored to have Dean Dance Barnes, who is going to give some opening comments. So thank you all.
Being sound, I didn't want to miss anything, but I'm so honored to be here today, and I want to welcome you all here, including those that are online virtually. And I just want to thank you for being a part of today's very important conversation. As Dean of the college, I can't say how much of an honor it is to be here. I always feel very honored to be a part of these occasions and these types of gatherings where we're sharing and engaging in knowledge. And one such as this that centers not just on research, but on relationships. It also centers on relevance, and most of all on responsibility. It's responsibilities to our communities we serve and the values we uphold, and to the future we are shaping together. The theme of today's event is in engaging communities to conduct impactful research. It could not be more timely. I feel in an era marked by what we find to be profound social, health, and environmental disparities, it is not enough to ask questions from a distance. The work that will truly change lives, change systems, requires us to be present, to listen deeply, and to walk alongside the communities who live the realities we seek to better understand. This, in essence, is community engaged research. It is rooted in trust, reciprocity, and humility. And is exactly what our speakers today exemplify. Dr. Ansuk Jeong work amplifies the lived experiences of Korean American families and highlights the resilience embedded in their everyday stories. Dr. John Mazzeo's collaboration with Sinai Hospital shows us what happens when data meets dignity, when predictive analytics are shaped not just by algorithms, but those on the front lines of care. And Dr. Maria Ferrera's leadership through the Center for Community Health Equity reminds us that institutional partnerships can and must advance equity if they are to be truly impactful. So each of these scholars remind us that research done with communities rather than on them is not only more ethical, it is more powerful, it is more sustainable, it is more human. And so as we engage in today's discussion, I invite all of us to consider not only what knowledge we are producing, but for whom and with whom. Because in this moment when trust in institutions is fragile and disparities are deep, we must double down on our commitment to justice-oriented, community-rooted inquiry. This is our mission. This is our calling. And I'm deeply proud that this commitment runs through the heart of who we are at DePaul and within the College of Science and Health. So I want to thank you all again for being here. And I want to turn it over to our distinguished presenters. And I'm going to sit down.
Thank you, and thank you to Annie for inviting me and the colloquium committee for inviting me. It's an honor to be here with all of you. My name is Maria Ferrera. I am one of the co-directors of the Center for Community Health Equity, which is a partnership between DePaul and Rush University. It was established in 2016 by Dr. Fernando de Mayo, and John Mazzeo had an integral role in it, and Dr. Raj Shah is my counterpart from Rush. He's a physician at Rush University. So one of the things, just as the mission, is to improve community health outcomes and contribute to the elimination of health inequities in Chicago. So when the center was established, there was a strong value in community partnerships, and that still continues today. So we talk about the four cores of the community health equity: direction, discovery, design, and dissemination. So discovery is, how do we engage in research that really centers community voice and how important that is, and how do we interpret those analysis and findings that really involve the community in our dissemination, and within our programming, what are community partnerships that are meaningful for us, that help us understand the evolving needs of community. Some of the focus areas of our center, we have partnerships with Chicago Scholars, which is a youth mentorship program nationally. We're doing a lot of work with immigrant health and mental health with the Coalition for Immigrant Mental Health. And we have a partnership with the Illinois Association for Free and Charitable Clinics. We're working with MPH over the last few years in their now biannual Health Equity and Social Justice Conference. Dr. Raj Shah has been providing youth mental health first aid training for the last couple of years now. We've been providing belonging workshops for the Chicago Scholars youth. We have developed a podcast that was built from our Voices of Health Equity initiative, and we've been doing annual reviews just to give you an idea of what we've been doing, and we'll be celebrating our 10-year anniversary this year. So we're excited about that. I just wanted to spend a few minutes talking about our community engaged, health equity focused faculty fellowship. And I just made a few copies here if you want to pass them around. So this is something we offer to all faculty, including CHIR, who are engaged in community centered research. So this was launched just a few years ago. We provide a small stipend for faculty, and then we also provide a stipend for the community partner. Right now there's a rolling deadline. So I just want to encourage you to encourage your colleagues to apply. Ansuk will be presenting today is our most recent fellow. But one of the things when I was a junior faculty, the STAIN Center that does value community engaged work has been incredibly supportive of the relational aspects of this research, which is really difficult to engage in, even when you're junior faculty. It takes time, and to do right by communities, it can be very challenging. So those relationships are so important. Checking myself as a researcher, why am I doing this research? How am I not centering the community? That has been the challenge with this type of research. So as a fellow with a STAIN Center, I know how important even just a little funding to support research, especially at this time when research isn't supported right now, especially community engaged research. So I do want to put this out there. Please encourage your colleagues and faculty to consider this fellowship. Right now, we just offered the fellowship to Dr. Molly Nutter from the nursing program, and we're very excited about her work. I just talked to her this morning. An amazing human being who's been doing healthcare work for many, many years now. It's fairly new to DePaul, so I think she's really excited about getting support. And one of these things she says is, you know, she's working in the Woodlawn community. She says, I'm not doing this for me, I'm doing it for them. So it really embodies the true spirit of this fellowship and any community engagement work that we want to support. So we're really excited to work with her, but I once again want to acknowledge that this is a rolling deadline for the application, so we really encourage folks to come talk to us if they have any questions about this fellowship. Previous recipients have done work with the Swedish hospital, Dr. Sonia Crabtree Nelson, around domestic violence, and Nyla Hoffman, who's been doing work with the Restaurant Opportunity Center around wages and working conditions for restaurant workers. So that's who we've supported before. Ansuk has also embodied the spirit. We're so excited to work with her and learn from her work in the community. So I know you're going to talk today, but I wanted to thank you for being part of our community and allowing us to learn so much from you. And that's it. So if you have any questions, let me know. But I appreciate you allowing me to talk about our fellowship. Thank you.
Try to clear the monitor and keep popping up. I'm Ansuk Jeong. Thank you for the nice introduction. And I was a lucky faculty fellow for the past 2 years, which coincided with my first 2 years back at DePaul, back at Chicago, but at DePaul. Life gives us lemons all the time, snow, winter, hazel, anything, and rain like today. What do we do with it? If you can make lemonade out of it, very good. And I'm going to share the stories, which is not working. The stories that I heard from Korean American families. Is it really? Why?
What's going on?
This.
Oh, the pointer is not working.
I think she's got do you have a video or?
Video? No.
Oh, you're just trying to advance the slides?
Yeah, right.
I think she preferred to use the pointer. It was working earlier, but we can always use the
Because you
keyboard.
click the Zoom screen, the slide presentation is no longer in front. So if you just click somewhere on the slide, yeah, try that.
Thank you. So I'm going to share these Korean American family stories of making lemonade out of a lot of lemons as immigrants, but at the same time, it's going to be what we as a research team learned from this type of collaborative research. The whole team is here to answer any of your questions. I'm going to talk a little bit fast because we have limited time here. To give you the background of the whole research is going to be the background of this talk, and then what we figured out, what we learned from these stories, because it was qualitative research by interviewing a lot of people. And then what do we do with it? When we figured out something, then there's next step. So I want to share your ideas as well as some insights that we learned. First of all, I was born and raised in Korea. This is Busan, harbor city in Korea. And then I moved to Seoul, that everyone knows as a Korean, the capital city of Korea. The difference in between these two contexts is like when you were born and raised in Oak Park, somewhere pastoral, and moved to Manhattan, not downtown Chicago, but somewhere, that megalopolitan type of a town. So that was my first culture shock. And then I was in Canada for exchange student, but it was undergraduate study, which is different. So when I came to Chicago, that was major second culture shock because I had to learn a lot of different things. So I went back to Korea to teach, to do my work, but I was one of 3 legitimately trained community psychologists in the whole nation of South Korea. So I was lonely, although my life was good, but lonely, I mean, professionally speaking. I had to explain the whole community engagement research to all the psychologists I'm talking about, right? Not just to mathematicians, physicists, but psychologists don't understand what community psychologists do. So that's how I wanted to come back in a way to learn more, to do something synergistic in this community of community psychologists, which DePaul boasts. So in DePaul, we have this Chicago as our classroom. So, okay, I wanted to reconnect with the community that I thought I knew. But that was the time point when the pandemic effect was almost wrapping up. It was 2022 and 2023. So when I was looking at this whole context, local context of community reconnecting, what is it? We are somewhere here as a particle, but then it's surrounded by this huge community. When I was reconnecting with some members of community that I knew like 20 years ago, 10 years ago, they were talking about a lot of different stories, which boils down to their concerns about caregiving to their parents and raising their kids as an ethnic minority in America. So all these things got me this idea of, okay, what can I do? Because, for example, one of the stories was this. My good friend of mine, she's a lawyer. Her husband is dentist. We can imagine a lot of resources. Yes, they have one of the largest mansions in their local community. She lost her mother-in-law during the pandemic, and the father-in-law feels different as a widower, right, after this pandemic. So she was approaching the father-in-law who speaks mostly Korean language only, but she speaks English very much more comfortably than Korean. So she was asking in English, what can I do for you? What do you need? And the father's answer, nothing. So nothing, meaning, does he need anything? No. Does he need nothing? No, not necessarily. He does need something, but he assumes she wouldn't understand, or I don't want to burden you. Or if I say this, I feel ashamed. So a lot of different textures are there. So that's what led me to start, okay, let's hear more from all these community members to see how their needs are shaped by this experience of pandemic particularly. And then there was this thing and CCHE who got me to this title of, okay, when I assess the needs properly in Korean American community in Chicago area, then I need to do something as an intervention. Still, I was driven by this such a medical model that when you don't have something, I need to provide it. Right? That was my assumption when I was approaching this community, that I felt part insider, as part insider, part outsider in a different ways. So how it evolved was by working with Hanwha Family Alliance, they, out of a lot of community organizations in Korean American communities, this one is almost the only one who survived like 40 years of service. So they flourished well and they have the best reputation in the community. So it was really lucky for me to be able to work with them. And then in recruiting, because even if you have the best model to approach the whole community for the benefit of themselves, it's them to receive it or not. So when I want to recruit certain participants, this was critical support when CCHE supported the staff members of Hanwha by having a stipend, and then bilingual RA was supported for the whole year, so I could do some proper translations that AI can provide, which was critical. So what I did was 18 interviews completed, first generation in acculturation or immigrant studies, meaning you were born somewhere else, but you moved. That's first generation. Second generation typically means you are born to the first generation in this new context, but here I'm using it as just the adult children who have some family members that you provide care in certain broad ways, general ways, and that family member should be the first generation. So that's how I recruited. Can you take a look at these numbers to begin with as my participants that I'm going to present the results out of? Do you see any problems here? Do you see any spaces to improve? You do, right? What is it? Don't smile, say it.
Maybe more male representation.
Great. That was the thing that we struggled a lot. Why don't we have male participants? Someone even suggested me to bring a male lab members to conduct research. But I don't know, we are going to talk about it. What does that mean? Maybe because women are more involved in a lot of community centers programs. Men also, together with the Korean culture that really respects men who are the authority figure in household. So you are not necessarily in the best position to talk about your issues, your hassles, your struggles as a Korean immigrants here too. So they don't come to be interviewed, right? That's one. Also, the city of Chicago versus suburbs, depending on where you live, resources are very different. Social connection, caregiving is very different because it also involves the mobility as well for all the adults, right? So all those we're going to talk about, but the results-wise, the focus was connection, social connection, as well as caregiving. So for social connection needs, yes, these categories are just something that you can connect really easily, but the issues, when you take a closer look at it, intergenerational issues in terms of social connection, when the older adults start start losing English ability, not necessarily as a natural decline of cognitive ability when you age, but also because of this vicious cycle of whom you talk to usually. So when you retire, you lose this social connection way more than when you were working. So you are using the Korean language so much more. So when you speak Korean language only, then this intergenerational issue within the family becomes bigger because you sometimes blame your kids to be too American because they don't act as the way you would expect your kids to do it. In our Korean saying, people say kids are the best pension. So they invested the whole thing, whole life in their kids' life as an immigrant, particularly. And when that doesn't come out of it, there's this guilty feeling as well as disappointment and guilty about disappointing your parents. All those vicious cycle comes here. Colleagues, we don't have this word even. Colleagues, yeah, they are acquaintances that you know at work, but after retirement, they become either friends or you don't know them. You disconnect with them. So it's more like friends from work, let's say. So they have these associations that were formed when they immigrated like 50 years ago. So sometimes it's still active, so they are connected. If you are losing this connection to church as well as association, then you don't have anyone else to turn to. It's totally your family only. So that becomes, for the second generations or other children, that becomes a burden because you have to take care of your life as well as your parents' life, essentially. And when we have the seniors, older adults living in the city of Chicago, a lot of participants were residing in this senior apartment. So they have certain programs and some social life going on within that building, which helped during the pandemic, right? Because you don't travel too much. So that was the social connection needs, care-wise, physically, psychologically, yes, of course, physical one. If you have serious condition like Parkinson or cancer, now treating under treatment, then that becomes the real physical needs that you have to have someone to take care of you. This, even if you are done with the acute treatment for your thyroid cancer, breast cancer, or some type of blood pressure issues or diabetes issues, all those are something that you have to manage well with certain support. Otherwise, it's more about driving. Driving, if you can drive, better, right? Because you have independence. That mobility issue, not only because of your physical condition to the level of disability, or how much can you have your own autonomy in terms of being mobile. That was important, as well as language. Even though they were successful engineers, even doctors in my sample, they feel like they don't speak good English, right? Like terms and conditions, all those fine letters in your medical bill or insurance type of a thing, you talk to your other children. So this whole thing puts you in a place where you feel like, am I burdening my kids or am I burdening the whole society? At 75, at 80. And that's related to your parent identity as well, because not only in Korean culture, I think it's universal. As a parent, you are taking up this role as a provider of care instead of receiver of care. So that transition triggers some guilty feeling, guilty about lack of independence, all these reliance, and at the same time, to the society. As an immigrant, even if you are now American citizens, legally speaking, psychologically speaking, how much do you identify yourself as a person who have contributed to this whole society to benefit from the social system? That's very low for immigrants. They don't take everything for granted, right? So it's the outsider perspective in a way. So this guilty feeling is interwoven not only within the family network, but also as a whole. So you again rely more and more on your other children, so much more. So what do we do? Before jumping there, as a wrap up of the whole finding was the needs that all the adults are experiencing are so dependent on demographics. If you are a man, woman, if you are older adults or younger older adults, or if you have someone to take care of you at home, do you live with them? Do you have a partner? Or this demographical basic information does have a lot of nuanced information when we talk about the needs that all the adults are experiencing here in America. Not only that, it was, think about the immigrants. Those immigrants were the ones who migrated trans-Pacific when garlic smell wasn't very welcome here, right? You smelled like garlic, you have the accent, all those, the reputation, the reception of Koreanness in America in 2025 is very different from 50 years ago, right? That's when people were talking in quote, saying someone who went to Seoul National University, which is a Harvard in Korea, was doing shining here, right? That lack of translation of your assets, your education, your credentials by migrating to new country was overcome by this type of resilience. That was so conspicuous when they talk about small things, big things, how they overcame it, how they take out of all these struggling points, challenges, and frustrations. Social connection, if you are connected well with your family, with your networks, then it's so much better psychologically as well. We all understand this connection as a strong intervention point, right? So that's what I'm taking to the next step. But at the same time, the paper now under review, the manuscript that we published together in our lab is, let's look at, although my original point was needs to be assessed, then I'm going to design an intervention to meet the needs. But they were able to, the participants were able to remember their first day of migration, landing in O'Hare, landing in New York, somewhere, almost as a photographic memory, right? What day of the week it was, all those numbers, everything they were remembering. So I had to align all those things chronologically, and there were chunk of time that they experienced this more commonly. Chunk of time they started shifting their attention from some microsystem to family so much more. And after pandemic, it's more on the family more. So that whole thing was figured this way. So they started relying on this microsystem, church, associations, and family all together, but they were experiencing definitely language barrier forever. It's persisting even till now. And community experience means discrimination, lack of translation of the assets we talked about. Also the community violence, because there were certain local communities that Korean immigrants started small businesses. And there were a lot of burglaries, robberies, and all these. At gunpoint, they talk about it, and that left a lot of traumatic psychology or perception of ethnic minorities in America, in Chicago area. However, this optimism, this resilience made it although this part means when you age, meaning it coincides with your retirement, so you are losing some networks. So again, it's more like they were the best resources and that's their investments. But at the same time, because you are so disconnected now with other local communities or mainstream, it's more burdening islands, which is an outcome of your trying to be self-sufficient as immigrants. However, the point here is the familiar resilience that I was noticing by the way they talk about it and all these outcomes. So what do we do? Fact number one, life gives us lemons all the time. Then what do we do? So why does it go back? The narratives needed translation. Translation, a lot of it was conceptual, meaning only people factors can be entered into, not AI can provide, right? Not only that, ecological translation for the members' engagement, meaning our lab members don't speak Korean necessarily. So when someone says racist remark, she was like, the quote goes, I'm not a racist, but, and she says things badly about certain ethnic groups, and then she says, oh, this is a racist, you can say. So all these mixed feelings about it, and all those things needed ecological translation. What I'm talking about here is my lab members, when we were presented this transcript with N-words or certain negative derogatory words about certain ethnic groups, my lab members requested me to have trigger warning, right? Which gave me a great learning there, right there. Yeah, my translation that's on the other slide, my translation does not stop at translating basic science to applied science, from academia to community, but also for different groups of people who want to understand what these nuances mean in real life. So all these constant translations are going on. And this as well, self-selected participants, we always experience it in any type of research, but why are they so marginalized, right? Someone signed up for this research even to be referred to a good psychologist, because I'm a psychologist, he believed, as a practicing psychologist, he assumed. Meaning, because of a lot of cultural barriers and his own understanding about mental health as a Korean immigrant in America, he didn't want to take the risk of being viewed as a person who needs help for the past 40 years. Now he's retired and he's really, really concerned about his own mental health now, so he is seeking out help, right? They are the voices who are not included in this type of qualitative research even because they don't come. But we need to learn from them. We need to hear their voices as well. So how do we recruit or approach the potential participants about whom we don't know much, right? That's a huge assignment that I need to do. And this researcher's personality we talk about as an insider and outsider, yes, I still am here on a work visa. So in a way, I'm an insider, but at the same time, to those immigrants who have been here for 40 years, 50 years, I'm a little bit outsider as well, right? So how do I cross this line to be beneficial to the persons that I'm working with? Not only that, as a faculty from a good institution, from a good educational institution, and women who don't have a family to take care of. So all these perceptions are going to be interwoven when they talk with me. and psychologists. When they know I teach psychology in DePaul, they assume I'm a clinical psychologist, right? So they start talking about too much that I cannot handle. Then my lab members from diverse cultural background, we need a constant translations by doing this community-based participatory research, because this whole study was developed, the research question was developed by talking to the community. And we work together, of course, and we are sharing, disseminating these results with Hanul as well as the whole community members. Then the new directions, what do we do with it as a core experience as a community psychologist that I longed for so much. So our lab's next step is how Korean American all these experiences were to your eyes or to your ears, right? Maybe parent-child relationship, maybe identity transition, all those can be very universal too, as well as men versus women participation, all these. So how do I integrate all these for intergenerational connection? So what we are working on at the moment is to run the pilot social connection program, which is intergenerational. We want to involve DePaul students as well, so that all the adults in Ebony Park, why? Because it's ethnically very diverse neighborhood, and that's where Hanul is located. So we are going to work together again, sustainability wise, we are going to involve some DePaul students as an important stakeholders to promote intergenerational connection. That's what we want to do in the near future, meaning within this year. And I hope to be able to report some results back to you later. But because I used too much time, I have to go. Instead, right before it, I want to say thank you to all my CARE Lab members, CARE, Chicago Action-Oriented Research with Elders Lab, and even this whole thing is designed by our lab member. Thank you again. When we have some discussions and question and answers, then our lab members will answer you. So let's hold our questions for listening to the next talk. Although I had to say too fast, I'm sorry, but thank you for listening.
Good afternoon. Thanks for inviting me. It's an honor to be here, and it's nice to be a part of this group and to also begin to meet people in the new college, having come here now probably like a year and a half ago. So it's kind of nice to be a part of these events and get to know people better. So I'm John Mazzeo and Department of Health Sciences, and I want to talk a bit about this project that I'm working on with collaborators from the School of Computing, and it's called SCHOLAR, which is an acronym for Smart, Connected, and Healthy Outcomes from Leveraging Assets and Research. Basically, it's a project that involves Sinai Health System with DePaul in order to do some work on how to improve a predictive analytics model for determining emergency room readmission of their patient population. So my collaborators on this project are Daniela Raiku, Rosalind Choa, and Jacob First, all from the School of Computing. And we're also working with Kelly McCabe, who is the Director of Community Health Interventions at Sinai Chicago. And she works specifically for the Sinai Urban Health Institute, which is kind of the research wing or unit of Sinai that does a lot of work on population health, public health, community engagement. And this work is funded by the National Science Foundation through their Smart and Connected Communities grant. The idea, I guess, kind of some background on this project is that several years ago, DePaul entered kind of like an exploratory relationship with Sinai to determine if Sinai could be how we could partner on research, teaching, and a variety of other things. So a committee was formed that involved representation from both sides to kind of explore possible ways to do this. And in this process, like faculty, like Rosalind from CDM became involved. She was a faculty fellow, I think, through CHE, was it? Or maybe she might have been through Stain. She was a faculty fellow. Yeah.
We've been collaborating.
Okay. And her work looked at some early pilot data about emergency room readmissions and what were some of the like social determinant of health variables, as well as other sorts of clinical interactions that might contribute to those readmissions. So she was part of this kind of early intellectual exchange with Sinai. And her work found that interactions with community health workers actually reduced readmission rates. It was one of the most significant things that was associated with reductions in emergency room readmissions. So then the kind of collaborating committee between DePaul and Sinai became very encouraging of, well, how could we support this? How could we push this further? And that's where this kind of grant came about. So it's a much larger project that builds on Rosalind's earlier work, but includes several other faculty to support in the computing side of it. And then one of the new aspects is to include myself in the project, which in my work is largely around involving the community health workers as a kind of like feedback mechanism, you could say, in terms of the production of the predictive analytics component. And also the community health workers as the designers for a data-driven tool that will help them do their jobs better. And that tool has not been designed yet. But the idea kind of like at the foundation of this project is that community health workers, and if you're not familiar with what they do and who they are, but these are people that work for the hospital system. They are not social workers because they don't have that kind of clinical social work background, but they're individuals that are usually have lived in the community area that Sinai serves and have an interest in doing kind of like patient advocacy work, or as well as kind of have some health experience, healthcare system experience. And they're usually assigned a set of cases. So like, for example, there are CHWs that focus on diabetes care and management, or asthma care, or behavioral health, or maternal and child health care. So the CHWs that we work with at Sinai kind of represent a variety of different areas, focus areas for the hospital. And the CHWs are assigned to patients that have been flagged by social workers at the hospital as being individuals that the social workers perceive as being at an elevated risk for perhaps being readmitted. So it could be someone who has a more complicated case. It could be an individual that their context or background or kind of life situation is more complicated and they may not have the resources in order to follow through on care or to do the sorts of preventive things, let's say for asthma, like home sort of improvements to reduce triggers in their environment that might lead to readmission. So the CHWs are assigned to individuals that are believed to have the elevated risk for readmission. And their primary job is to first assess what are the needs of their client population. So like they'll conduct an intake survey, or it's kind of like an interview that they do that covers on a series of topics. It could be about, do they have a primary care provider? Do they have insurance? Do they have housing? Do they have adequate food? Are they able to get prescription medication? Can they access transportation? So it includes the kind of clinical pieces, but also all of the contextual pieces that influence clinical outcomes. And in that intake survey, they make note of the areas that those patients need support with. And then the next job is to try and connect them with those support resources. So they'll provide them with referrals to housing services or food banks, or they might try and set them up with a primary care provider. They'll do a variety of things in order to make sure that they can get those needs met. This kind of work is extremely time intensive because it requires multiple meetings with patients, conversations about how they're doing, what's going on. And in many cases, those patients, they form a good relationship and a strong bond. They said the community health workers are one of the only individuals that, in terms of listening, they'll do a lot of kind of sitting, listening, and talking. Many of the clinical providers just don't have time to do that. So the CHWs are there to listen and have patients be heard. And then there's a lot of follow-up to ensure that someone is following through on these resources. So if it's not the patient, they're working with family in order to get them the care, those things that they need. So anyways, that's all to say that community health workers are an important kind of link between patients and clinical outcomes. They connect patients with resources in the community and also align them better with resources at the hospital, clinical resources and all that, in order to reduce readmissions. And this idea of reducing readmissions is important for patient outcomes, but it's also important from the hospital's perspective, because it's one of those things that you get penalized for by the federal government when it comes to Medicaid and Medicare. Readmission is one of those things that they look for. So reducing the rate is good for everyone. So the idea behind this project is trying to see how can we use a machine learning model to help improve the targeting of patients for community health worker intervention. So that way we can reduce emergency room readmission. And again, like at Sinai, they have maybe 10 CHWs that work with patients, and they need many more, but they just don't have the capacity to have more CHWs, and there's just limited resources. So the idea behind this model, why it's attractive to Sinai, is like, how can we do more with what resources we have to have a greater impact on the patient population that we're serving? And then the other piece that I would consider to be novel here is that they're not just using the data set, the patient data set at Sinai in order to make predictions about outcomes. So they're not just doing like multivariate modeling sort of work, but they're trying to involve the community health workers in evaluating those models and getting their opinions on what this algorithm might look like in order to predict those outcomes. So this is what this kind of what we call the scholar model, how it works, and this is all of kind of the data inputs and what our outputs look like. So you have this kind of on the top, this dynamic SDOH data. This is the data collected by community health workers. That's this intake survey. So this is that multiple item survey that they go through with patients to determine needs. And then you have EMR data. So this is collected by clinical staff, and this is what you have in tabular form. It's patient data essentially. And then there's these dynamic risk assessments. These are assessments of patients that's done by social work, and this is what connects patients to the CHWs. In the middle is that predictive model, which is kind of foreign to me, but this is why we have a interdisciplinary team. And then in terms of the kind of how all this, where it centers on are those CHWs. And that's what I'll talk about today, is kind of how CHWs are involved in this process of taking data in, working with a predictive model, and then to accomplish these, improve predictions, improve patient outcomes, better resources. So this is a 3-year program or a 3-year research grant. We're just in year 1. So we're kind of beginning to assemble the data and work with our CHWs in 2 areas. We're doing curriculum development and training. So we're working with the CHWs to provide some very basic training modules on data science and trying to connect those basic ideas about what is data science to their roles as being a CHW. And then we're also doing focus group interviews, and I'm running the focus groups about getting them to begin to think about the data that they're collecting as a way to predict outcomes. So getting them to kind of be able to apply data, think about a function. And the piece that is, again, novel here is this, what in computer science they call human-in-the-loop strategy, which basically means you're using humans in order to prove the outcomes that are being generated by the model. So in a sense, kind of like the presentation before us when we were talking about translations, you can get an AI translation of an interview. But unless you have someone proof that interview and really make sense and prove like this is really what it's about, it doesn't, sometimes the AI doesn't generate what it should be. So in this case, it's the same thing. We're getting the CHWs to determine if the significance of these different SDOH variables in order to predict those outcomes. So they're being involved in this process. All right, so I'll talk quickly about the focus groups. And at this early point of the grant, this is kind of very formative. We have not yet taken the focus group data and turned it into predictive analytics recommendations. That's a year 2 thing. Right now, I think the points that were made by Dean Dan Barnes at the beginning about like building trust, relationships, and rapport, that's what we're doing in year 1. So it's about being able to have these connections with CHWs and get them to kind of talk through what they're seeing and what they think, and to see themselves as experts in this area. And once we have that kind of expert perspective established and respected by themselves and kind of built into the project, then we can begin the process of designing a deliverable. So the first focus group was to have them work with the SDOH data that they've been collecting. And they have a survey that involves about 20 individual variables, and that's what these cards are about. So each card is one of the items on their SDOH survey. And I had them walk through a very simple like ranking activity. So everyone gets a deck of cards and they think through what are the most important variables in your deck, most associated with emergency room readmission. So this is like the first time that not only are they collecting data for the survey, but they're actually getting a chance to think about it, reflect on the data, and begin to make associations with outcomes. So it's a simple kind of activity. And what I did with them is after we completed the activity, we ran through the outcomes. So it was a learning opportunity to think through how do you not just capture the data in this ranking sheet, but now you're trying to interpret and analyze the information that they've generated through this ranking activity. So for some of them, it's one of, maybe not the first time, but a long time since they've been working with tabular data and thinking about measures of central tendency and thinking about agreement and how do you measure agreement and how do you generate kind of group averages, the medians based on individual sort of responses. So this is a slide from one of the training activities. But each one of those columns is one of the variables on their intake form. And what they did was they ranked where that item fell within the deck. So one being the most important thing for readmission. And based on this, we walk the CHWs through the process of establishing agreement or talking about agreement. And in this case, we use like median absolute deviation as a way to talk about like this dispersion around this kind of median and how much, I guess, in a way, agreement and disagreement there is about certain determinants that they've identified. So for example, many of them agree that, all of them rank diabetes and asthma and primary care providers high. That was kind of the median outcome of the DEC ranking. But there's also strong agreement that diabetes and asthma are highly associated with emergency room readmission and so on. So this is kind of getting them to begin to think through the information they're collecting and what it means. And then an interesting part that came up more recently was about thinking through how this compares with tabular data. So the CDM side is running the patient data and generating their outputs based on their models. And we showed that the CHWs at one of the sessions, how their results line up with the data. And we've just started to have this conversation about, well, what sort of similarities and differences do you notice? And like there are some like immediate things that are highly ranked by both, like diabetes and asthma. Hypertension is up there. And at the bottom, you see low priority on things like legal help, nursing home support, things like that. But then questions come up in this conversation and that were driven by CHWs. Really interesting is like, well, why are there differences? And we started talking about the time at which patient data was captured, how that's done, how this is different, kind of like biases that may come up in CHW results, not necessarily negative biases, but the fact that they're probably thinking about the patient they served in the past week, and they might have a certain kind of portfolio of patients, like if they're working with asthma care patients or behavioral health. So we have a really interesting conversation about the sources of data, how they compare, how they differ, and what those reasons are, as kind of like the first step to getting them to think about, well, now how can these two sides or two approaches be combined to create a better predictive analytics model? That's kind of a year 2 thing. We also did another activity with them around pile sorting. And the pile sorting activity was kind of like to get them set up for decision tree and random forest modeling by the CDM folks with their data set, but was having them to think about clustering of variables and associations of different items. So the way that this works is they get another deck of cards. It's the same deck of cards. And they're asked to create piles of variables or create piles of cards that go together. And that's the only instruction. And people generally came up with maybe like 4 piles, sometimes 5 piles. And each of these piles is supposed to have a title and a theme. So like, why did these things go together and what are those common features? And we have a focus group discussion about that. So people share their piles and we talk through the reasons for it. And the way that this data is collected is entered as a matrix. So where there are ones, this is where those 2 items or those 2 cards happen to be in the same pile. So 1 means those things appear with each other in the pile, and where there's a blank or a 0, like those things are not associated. So we put together these matrices based on the pile sort activity. We kind of began to talk through this with them as well. And you'll get like 1 of these for each individual person. So then the way the pile sorts work is, imagine you took 10 pieces of paper and they're all matrices, and you put them on top of each other, and then you like added down those cells in the papers. We had 7 participants in this group. So in a cell like this one where it says 7, everyone had a 1 in that cell all the way down that pile of papers, right? So this is just a way of just summing it up. But based on the summing of results, you can do a multidimensional scaling process where you enter these like similarity numbers, you use the multidimensional scaling process, and that will create these distances. They're kind of just distances in a normal space, like an XY sort of plane. The distances in themselves don't really mean anything in that they're distances to each other, and then those things are plotted in the scale and outcome. So on the left, you'll see these are all the distances but through the MDS process based on the focus group, the CHWs, and you can see some clustering of SDOH items. And I've kind of like created some, I've circled here some things that seem to have some logical sense, as well as the distances appear to be closer. And this was the starter of a conversation with the CHWs about, again, like how do you organize, how are patient data organized? What are the most important variables to each other?
Don't interrupt. They're saying that they can't see you speaking, that they can only see the slides. So I don't know if we just need to turn the video back on. Sorry to do that. Not sure how to fix that. Sorry.
If it's that camera there, it's.
Oh, yeah, it was on earlier, and I'm not sure we were able to see, but then I was getting messages in the chat, so I know. Yeah, I don't know if it's worth using at this point, but I just.
And just the process comment, we have about 10 minutes left of the session, so.
I thought it might be an easy fix. Sorry about that, guys, on Zoom.
All right. Well, I'll just quickly wrap up and then we can probably pan out so you can see everyone. Though we're moving on to the education. We've done the educational session. We have one more to do on machine learning. We're gathering feedback from CHWs in the process, and we're getting so far positive feedback about the sessions. And what has been key is getting them to apply this information or these ideas back to their roles as CHWs. So that's been a challenge. That's been their constant challenge to us in the room is that, okay, this is interesting, I suppose, but how does this relate to me or how does this help me do my job better? And that's been something that has been good for us, a good reality check to keep us relevant. Next year, we're going to be moving into the design phase, which is taking this kind of preliminary information and approach, and then having the CHWs participate in the actual design of the analytics model and also some sort of tool. And it could be a dashboard, it could be an interface on like a screen, it could be something that helps them with patients, it could be a variety of things. We're keeping this open so that way the CHWs have more control over what they will choose to do with the data and what they want the outcomes to be. What do they want to accomplish? So that's the conversation for year 2. So I will close there. I think we have 10 minutes for questions. So.
Big thank you to our 3 speakers as well as the dean. So we open it up to questions, comments. Yeah.
For John, and I know you're an anthropologist, right?
Yes.
I'm just curious about the study is really interesting, and I'm just wondering, is there room for story? What role does story play in how you understand what's happening with housing and food? And like we know what social determinants of health, like they're clear, but then what's happening in this neighborhood?
Yeah, so in the focus groups I've started to collect those stories. I didn't get a chance to put them up here, but in the design phase, that is going to be like the crucial part is thinking about like, what are the patient stories that stand out as exemplar and how will that then help them craft something that a data-driven tool that will help them address these real contexts. So those stories are going to come out in year 2 for sure.
I also had a question for John. Great presentation. So I might have missed it, but in the data-driven approach, you're using patient-level hospital data?
So for the tabular stuff, like they're using the patient data.
Got it.
Yeah.
So I was wondering, is there a way that you're using those data and weighting them for issues related to equity and health equity around different marginalized identities? So maybe a minoritized identity, their kind of patient data would be weighted differently than non-minoritized identity, or houselessness versus housed. Yeah. Would there be a way to kind of ensure that those who are the most marginalized, that their data carry perhaps more weight? Or...
That's a really good question. I don't know how they're doing the weight, if they're doing data weighting. I know that the patient data that they have will likely not have many of the SDOH that we have in the CHW. The data sets are kind of in some ways different because they don't collect stuff like housing or other determinants. So it will be hard to do some of those things, but they do have all demographic data and they could use it for weighting. So it's an interesting question. I can't answer.
Great work.
Thanks.
I'm interested to hear from the students in Ansuk's lab. Maybe you could comment on, I don't know, anything you want to highlight about your experience or what you learned.
I've been thinking about, I have a sort of like discussion thing I've been thinking about when I saw Vietnamese poet and author Ocean Vuong. He was in town last week because he wrote a new book and he's doing a book tour. And something that he writes a lot in his works, and something that he talks about, and something that he lived through a lot was circumstantial family. So a lot of like literature, you kind of see like people um, fixing like family relations by blood or finding family. But a lot of his stuff is writing about circumstantial family, which is when you have a bunch of people in the same room, usually at work. For a lot of Vietnamese people, that was working at like nail salons, which was turned into a place of work, but also like a community center, a religious space, a daycare, and how that kind of turned into almost what we are trying to do with connecting intercultural and multi-general generations and groups. And I was kind of, and he had this anecdote that he told that was really powerful when he was speaking, where he was talking about how when he was working in Boston Market in Massachusetts, or sorry, Connecticut, during the height of the opioid epidemic, at the epicenter of the opioid epidemic, how like all these people that came together found family, or all sorts of different places in the world, all kind of just congregated here because of circumstances and poverty and desperation, and how that kind of led to at one point someone after having a call that their brother was in the hospital because he had overdosed. All of them kind of just like congregated and helped her just like grieve that. And they were all people that kind of just came together and create the connections that we're trying to do with that. So, and I was kind of wondering, is there anything in that circumstantial family structure that is worth replicating? Are there factors of it that can be helpful in our academic setting of trying to connect people? Is that the thing that's worthwhile to do, I guess? Because they did have the connection, they had the common goal, they had the proximity, they had everything, but it was a really kind of sad and desperate situation. I was wondering, like, is that what our intervention is doing, or is there something that we can strive for that's better? I don't know. Just opening it up. A lot of the times, it was a lot of problems with their kids as well, because obviously, like immigrants, like rely a lot on the kids to translate. Um, my sister did a lot of that because she was older than me. And it's kind of like how do we have that thing, but have them branch out of their families, break out of that family island. Um, I think our goal with the 10-week the 10-week sessions can be helpful with that. I'm thinking about something with food. It's really fun.
So in terms of the common goal and the bonding that we want to promote in certain communities, is it really possible to approach top-down as someone outsider of that local community even? We just come there as if we are going to solve their problems. But then with this intergenerational piece with the DePaul members, we are going to open to the participants' voices to shape the whole content so that there can be the piece that's bottom up, that's for our own needs instead of someone else's dictated needs, solutions for those. So it takes time to integrate all those voices, to listen to all those voices, but that's
doing at our center is looking at the concept of belonging, a sense of belonging as a counter to health issues or syndemics. And I think what you're kind of getting at is how do they find a sense of belonging, which is a protective factor for health or mental health, arguably, in other spaces that it's not traditionally like we traditionally think of the family as the center of support, but that's not always the case. And they have to look at other spaces to receive that support. And that really is critical to when we're trying to understand what's preventative, what's promoting health, right?
The circumstantial support networks that you're talking about, I think, I mean, you gave a particular example that's out of desperation and a particular set of circumstances, right? But I think those happen all the time. Like, people have, say you have a medical condition and you affiliate with an online group and you get support from that because of your circumstances. So, so I think those are good things to think about. And I think they're happening. Maybe they don't happen often at a place like Boston Market, but I think they do happen sort of naturally based on people's circumstances. So, yeah.
It just so happens that when like you're an immigrant and you only speak that one language, it kind of is a very specific places that happens. And can that happen? Will they be willing to do things that are outside of what they would normally fall into?
Yeah.
That's why I kind of like your idea around food is because there could be some interactions that are not language heavy, but are maybe art-based food, other sensory sort of things for exchange that could be good ways to build bonds with people outside of their kind of language zone.
Yeah. So it's 1:30. We said we were going to end at 1:30. I think we should end. But thank you all so much for joining the conversation. And we did bring some bags. So please take some food with you, like a lot. Take a lot of food because I think there's a lot of food. So, and especially